This week on the BackTable podcast.
I think the most important thing you can tell someone who's kind of just getting started out is be comfortable saying, no, I have nothing I can do. Eventually, as you get more experienced, you'll start saying that less and less and less and start taking on crazier and crazier and crazier cases. But at least in the very beginning, be comfortable saying, like, if it's going to be really difficult for any treatment modality, feel comfortable saying there's nothing I can do here. Conversely, for your first ablation case, highly recommend segment 5, segment 6, see it under ultrasound. You're going to be so nervous just from doing your first case. Don't make it hard by making it hard localization. And choose really easy cases to start off with because you're going to have great results. It's a fantastic technology. It works. It's been proven to work for decades. And so just make sure you can utilize the technology where it really shines.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of the podcast on iTunes, Spotify, or backtable.com. Welcome to the BackTable podcast. This is Mike Barraza recording from Baton Rouge, Louisiana. I'm joined by Dr. Zach Berman from UC San Diego. Thanks for joining us today.
Thanks for having me.
We're going to talk about multidisciplinary approach to HCC and microwave ablation. Is this a large part of your practice?
Yeah, so I guess I can describe my practice a little bit. So I guess we would consider a hepatobiliary interventional oncologist. So a vast majority of my time is spent, just doing liver cases. Over the past couple of years, I've also started to experiment with pancreas ablation as well. Almost all of my day is spent mucking around in the liver and wouldn't have it any other way.
That's awesome. And you have residents and fellows joining you for these?
Oh, of course. Yeah. So we're a full training program. We have 9 senior residents this year. You're always with someone.
Man, that's awesome. I'm in private practice, but we're in the largest medical center in Louisiana. And so we see a good bit of volume. No residents and fellows for me, but I like to think we're pretty high level for what we're doing. So at UCSD, who all is involved in the treatment decisions for patients with HCC?
Yeah, so I guess I can talk about the whole pathway of how they come. So there's kind of 2 main pathways that they end up, in our care. The most common way is through our transplant program. I think that's where, a vast majority of them come. And so usually it's somebody in the community getting their HCC screening, getting their ultrasound. Maybe they got a CT or an MRI, show new liver mass. They get referred to hepatology. Those are usually the gatekeepers of these patients. Once they have a hepatology appointment, but before they see a hepatologist, they're presented at a tumor board. And so we present all of our HCC patients at our tumor board, which actually just finished about an hour ago. So I'm coming off fresh from it. So all of the patients are kind of talked about in a tumor board. And I'd say that's how most of our patients come. Occasionally they come through surgical oncologists, get a direct referral from the community or something like that. But a vast majority come through our transplant program.
Okay. Mine is primarily through tumor board. We have a dedicated hepatobiliary tumor board. Interestingly, the surgical oncologists tend to be the main gatekeepers where I am, and sometimes a medical oncologist. And then, of course, I'll get the occasional referral from somebody who got sent directly to surgical oncology, looks at it, it's like, I can't resect this. Can you ablate it or, do other kind of liver-directed therapy?
Yeah. It's an interesting disease because it has a lot of players involved in it because you're treating 2 conditions, both the tumor and the underlying liver disease, which makes it pretty unique.
So who all attends the tumor board?
Yeah, so it's actually a pretty busy tumor board. So we have 2 tumor boards. We have just the general GI tumor board where you'll see a lot of cholangiocarcinomas, maybe metastatic disease, pancreas cancer, GI, etc. And then we have a dedicated HCC tumor board just because our volume got so high. And so it's a dedicated HCC tumor board. We're capped at 16 patients a week and we always hit our cap. The people who are present are obviously the general, the usual suspects, the surgical oncologists, the hepatologists, obviously interventional radiology, medical oncology, diagnostic radiology. But I think what's really unique is, especially for these patients going through the transplant pathway, they have a lot of additional stuff that maybe a lot of IRs are not really used to incorporating in their practice. So there'll be a financial counselor, there might be social workers, there's going to be your transplant coordinators, as well as kind of our transplant nurse practitioners. And really, they are some of the biggest gatekeepers in this entire pathway because you're going to be treating their tumors and everything like that. But the definitive therapy is going to be their liver transplant. So getting them to that point is super important. So as important as I like to think I am at tumor board, I really do think our transplant coordinators and MPs are kind of the big players there sometimes.
How does that work for the patients that are on the transplant list and, they've got lesions that are either Milan criteria or however you want to evaluate them? Do they know where these patients are on the transplant list, the ones that are going to be nearing transplant?
Yeah. And if you are going to be treating HCC, particularly if you're in a transplant center, it's super important that you yourself know the transplant criteria, because you can really mess things up if you end up treating someone who's not at the appropriate stage. It's super important you know kind of that and working with them. But like I said, all of our patients are initially presented before they even see a physician. At our tumor board, a decision pathway is made about, are we going to treat, are we not going to treat, or how we're going to treat, what modality we're going to use. And then they usually start their, I call it their cancer journey, at the transplant visit initially. And at that time, they usually get a simultaneous referral to see me or one of my partners, and then we discuss treatment. And so the way I describe it to my patients is everything is going to be done in parallel. So I'm going to be treating the cancer, I'm going to be coordinating the biopsies if we need to do that, et cetera. But, they're also going to be behind the scenes, making sure you get your echo, making sure you get your cardiac cath, making sure you get everything else you need for a transplant, because, there's no way I can keep track of that. So everything's in parallel, and I treat the cancer. And what I like to tell my patients is my favorite day is when you fire me when you get your transplant and you don't need me anymore.
Right. Absolutely. You guys are in the tumor board and you're presenting these patients. I assume the diagnostic radiologist runs through the imaging. And how do you guys as a group kind of determine the best treatment option?
Yeah. So, it all starts with the diagnostic radiologist. We're pretty biased towards LIRADs. We're one of the centers that help generate it. Let's say something is diagnosed as a LIRADS M. You can't just jump straight to treatment. Now we're talking about biopsy. So you can kind of discuss that. And then you can get to, let's say, some things like LIRADS 5. They're within my Milan criteria. They're going to get listed for transplant. We want to do some sort of bridging therapy. Until then, loosely-ish follow BCLC. I think most places these days are kind of following the concepts of BCLC, and that's kind of how we think about it. Someone is, let's say, early stage disease, BCLC-A, maybe early B. We try and get them to an ablative therapy. And that's kind of what BCLC recommends. It's either surgical resection, transplantation, or ablation. And if none of those are an option, they consider transarterial therapies. And obviously, I have my biases towards that. But we try and get patients to an ablative therapy, in my opinion, either percutaneous microwave ablation or ablative radioembolization.
So ablative radioembolization, is that included in, when you say an ablative therapy?
Mm-hmm. Yeah. So when I use the word ablative, I guess in my mind, conceptually, what I'm thinking about is when, the tumors, the liver's taken out at transplant and they're looking at it under a microscope, I want to make sure every single tumor cell is dead. I want, and there's been large cohort studies, my center included, looking at 3,500 patients. And they show that if you're able to kill every single tumor cell before a patient's transplanted, the outcomes are better, both overall survival and recurrence-free survival. So in my opinion, I like to optimize transplant more than just bridge to transplant.
So when this comes up in tumor board, they present the imaging. How does it get to the point where you guys are deciding on ablation, either percutaneous or with Y90? I mean, do you just step in and say, this looks like a great candidate for me? Or is everybody kind of, in the group comfortable with what we can offer?
Yeah. So, and this is kind of the hardest thing that I wish someone taught me in fellowship. But, when you're in your fellowship, you're always worried about, can I get the catheter in the right place? Or am I going to see my needle under the ultrasound as I'm doing anything? But it's really the interpersonal skills that are super important. So, over the years and over experience, you develop a reputation with your group. And so when I say, hey, this is a really easy microwave ablation for me, or hey, this would be a really difficult microwave ablation for me, I think ablative radioembolization would be better. They kind of just take you at face value and say, okay, like I trust you. I trust that you know what you're doing. And what I really like about IR is that we have a whole bunch of different therapies that we can offer. We don't have to just be offering one. And I think, having the flexibility to feel comfortable with all of these therapies really makes you a much better interventionalist.
Yeah, I'm with you. One of the challenges I had early on with tumor board, which is to this day how I get most of my referrals, was saying no. And somebody presents, a really tough lesion. It's like, we really need an ablation. It's like, all right, I'll do this. And sometimes they really come down hard on that. And it took me a while before I could say, like, no, this is not the right move. We should do, a Y90 or something else. And that took me a while. It was too much saying yes.
Yeah, exactly. But you have to do that in the beginning, right? And that's the only way you're going to gain the trust. And you build the political capital, and then you can spend the political capital in order to, do what's right for the patient.
And it helps you get better.
Mm-hmm. Oh, definitely. I've definitely done some things sometimes where I'm like, I definitely learned some things here.
Absolutely. So when we're talking about percutaneous ablation, why is the primary approach microwave rather than RFA, IRE, or cryo? I know there are exceptions, for everything.
Yeah. So let's start with the easy one, which is radiofrequency ablation versus microwave ablation. So the quote unquote thermal ablation technologies. If you were to look at the size of ablation, it's bigger with microwave ablation. So you have a much better chance of getting adequate margins, which we can talk about in a bit. It's easier to use. There's no grounding pad. You don't have to worry about that. Issues with, large blood vessels causing a heat sink are less of an issue with microwave ablation compared to radiofrequency ablation. And then frankly, the ablation times are significant. Less time with anesthesia, the overall procedure time is less. It's one of those rare circumstances in medicine where there is such thing as a free lunch. You do get a free lunch with going with microwave over RFA, at least in my opinion. The other technologies you mentioned, cryoablation, there was a lot of scare in the beginning with cryoablation inside the liver because of cryoshock, but that's when people were using it, surgically open and doing big ablations, and they were getting a lot of this, release of antigens and stuff like that. For small tumors in difficult locations near sensitive structures, I have resorted to cryoablation, although I will say microwave ablation is definitely my main technology. And then IRE is really interesting because you can ablate kind of right in the middle of the liver and get away with it. So difficult locations I like for cryo and IRE, but your workhorse for me is microwave ablation.
One thing I hear more and more in tumor board about, and kind of always for all my tumor boards, that the one I'm kind of battling with is the radiation oncologist. And recently I get a lot more offerings from them to perform SBRT for these lesions in the liver. Are there any circumstances in your practice where SBRT is a better option than either percutaneous ablation or transarterial therapy?
Yeah, definitely. At least in our group, for the most part, if they're not a candidate for, let's say, percutaneous ablation, we usually resort to ablative radioembolization. And you can think of circumstances, particularly with tumors kind of in the middle of the liver, or tumors that have poor arterial supply, or for whatever reason, they don't have, arteries that can get there, to do ablative radioembolization. Or maybe it's a tumor in a location where you'd be treating a large amount of liver parenchyma, small tumor in a large liver parenchyma, which may not be amenable to these types of therapies. But going back to how I think about ablation, it's, as I said earlier, it's every single tumor cell being dead. At least, that's the intent of treatment. And I think if you look at a lot of the radiation pathology studies, both percutaneous microwave ablation and ablative radioembolization have really high 75% plus rates of complete pathologic necrosis. And there's very few other therapies that are able to achieve that.
That was going to be my next question, Zach, is what does the data tell us about microwave ablation and HCC?
It's interesting. So, the question is, how did it end up in the guidelines as being kind of like the number one recommendation next to liver resection and BCLC? So the 3 randomized controlled trials showed that the overall survival at 1 and 3 years was the same between the 2 different modalities. The complication rate was significantly less inside of the percutaneous ablation cohort compared to the surgical resection cohort. We're actually seeing that resurgence again today. The most recent oncology conference, the at least abstract from the collision trial, which was done in Europe, looking at microwave ablation for colorectal liver metastasis, where patients were randomized to either surgical resection or microwave ablation, showed no difference in overall survival. So we're starting to see repeatability of the data, and again, in different cohorts, where the first 3 trials I mentioned were done in China or Asia. The second other trial was done in Europe. So it's reproducible, and therefore I think it's legitimate.
So what about in terms of size for a lesion that you're looking at for percutaneous ablation? I know that some of the data has shown 3 centimeters as an important number. How is that how's that addressed in your practice?
Yeah, so this has really evolved over the past, I'd say 5-7 years. So maybe 7 years ago or so, if a patient had a 3 to 5 centimeter tumor, we were talking about TACE and ablation, because once you get to that size, you really do need to have the addition of the TACE. There's been randomized evidence, I think it was 2012, that showed that the addition of TACE to RFA significantly improved survival, particularly for these larger tumors. So it used to be the case where tumors 3 to 5 centimeters, I would, consider TACE followed by ablation either the next day or a couple weeks later. However, these days, with kind of the increasing evidence for ablative radioembolization, 5-centimeter tumor, I think they're best served off with that. And I think, inverse, there's really small tumors that are best served off with microwave ablation.
I'm with you. Okay. These patients can be very challenging because of comorbidities and sometimes tenuous performance status. How do you approach these in order to treat the sick patient appropriately and effectively and, of course, safely?
Yeah. So like I said in the very beginning, it all kind of starts with your multidisciplinary team, right? So a lot of these patients have ascites. A lot of these patients have sarcopenia. They have a lot of other conditions that are high risk for variceal bleeding, et cetera. So really a close collaboration with your hepatologist is really helpful because they can really optimize a patient prior to your procedure, or at least help to optimize. I've had patients who you see their scan in tumor board and it's just all ascites with a tiny little liver inside of it. And by the time they come to you for your ablation, their ascites is all gone. And, obviously whenever you think about ascites and ablation, you get nervous, right? And so it really is that interdisciplinary collaboration between them.
Yeah, I'm with you. So, you're in your tumor board and, we've presented a patient, and as a consensus, you guys decide that microwave ablation is the way to go. What happens next?
Yeah, so we see the patient in clinic. We're usually pretty quick. There's a lot of things that COVID really made better for us, and telemedicine really helped out a lot.
Absolutely.
We have a huge catchment area. California is a very large state, and some of my patients will come 3 or 4 hours away for this therapy. I really hate to have them come for a clinic visit when a telephone visit could be more than enough.
I do that all the time now for all kinds of things. Like if you're traveling more than an hour, let's just talk on the phone. I can't review their imaging with them. I can't, do an exam, but how great of an exam was I going to do anyway? And so, I like having these conversations with them on the phone as well.
Yeah, so teleconferencing's actually gotten a lot better. So we use Epic as our EMR, and there's actually native video conferencing as part of it. You can actually share your screen. I think Doximity can too. We use Doximity occasionally as well. And so you can actually share your screen, and so I can review the imaging with the patient as they're at home. We agree to do the procedure. They have their clinic visit with us. The clinic visit with us can usually be done within a week of the determination of that, and we get them set up for the ablation.
Man, that's awesome.
I wish I could say I did the ablation within a week too, but there is a little bit of a delay before we do the ablation.
I think that's reasonable. All right, well, let's move on to talking about how you actually do your ablations. And to me, the most important step is planning it out. And I just want to hear your process for how you take a patient who's going to get an ablation and plan out your approach.
That also has evolved over time. So initially, obviously, you look at the cross-sectional imaging and you think to yourself, is there a way I can do this under ultrasound guidance? Because obviously having real-time visualization of your needle is super important, can make the procedure, at times feel trivial. But we started using stereotactic guidance for a lot of our procedures, which, sounds really new and sophisticated, but the Europeans are way ahead of us on this one, and they've been using it forever. And it's just making it to the US now. And so you can start to think about, how the guidance, would kind of think about navigating it. And so I started to think about, how do I want the room prep? With ultrasound, I might have them a little bit decubitus in order to see up there. But, if I'm using a guidance, I may not need to do that. I may be able to keep them supine, which makes the procedure a lot easier for me and the setup a lot faster.
Explain to me how that works, the stereotactic guidance.
Yeah, so there's a bunch of different kind of vendors and different ways of doing that on the market. We've used robotic guidance, which comes with that. So I'll start with, I guess, the traditional way of how I do it, and I'll compare how I do it now to that. So traditionally, the patient would come in, I would do an ultrasound. I could see the lesion, it would be prepped, stick the needle probe in, do the ablation, take everything out, and then I would do a contrast-enhanced CT, arterial and venous phase. Yeah, to make sure I got the lesion, make sure I got margins, which we can talk about in a second because that's really important. However, once we started using the robotic guidance, one of the first parts of the procedure for the robotic guidance is to do a contrast-enhanced CT, even before you start. So patient's prepped, ready to go, do a contrast-enhanced CT with apnea, and then you can then plan your trajectory from there. And you plan your trajectory. If you're using robotic guidance, you're able to then have the robot help guide your needle into where it needs to go, or what other stereotactic system you're using. And then I do another non-con CT with the needle in place. And if you do an apnea at the same level of respiration as the first scan, a lot of modern PACS clients can actually do co-localization between the two. So you can actually click on your contrast-enhanced CT and click on your needle tip, and they'll perfectly co-localize. And so I found that to be a real big game changer for me, because I remember looking at some of my ablations, like measuring distance from portal veins or measuring.
That's like half the ones I do.
Yeah. And so kind of leveraging on-table contrast enhanced CT with like good co-localization between your scans can really make you feel comfortable about where your needle is in the right place.
So when you're doing these primarily with ultrasound guidance and you get your needle in place, do you image with CT during the burn?
I'm always so nervous, right? So most of these cases end up going intercostal with their approach.
Yeah.
And I just had it like 1 or 2 cases where the patient breathed the needle like 2 or 3 centimeters back. And if you're starting your burn, you lost your ultrasound. Like once you get the air bubbles, you can't see anything. So no, I do everything under ultrasound so that my hand's on the ablation probe the entire time, making sure it's in the same place.
And so on your post-ablation scan with contrast, what are you looking for?
Yeah, so the number one thing I look for is complications. Make sure there's no arterial, or venous bleeding as part of it, because we've really migrated to a same-day discharge, and we feel a lot more comfortable with the same-day discharge with no bleeding. But there's a lot of emerging evidence coming up, particularly in the colorectal liver metastasis space, that getting a minimum tumor margin is critically important. We've always known that, but a lot more prospective evidence is coming out that getting a minimum tumor margin is super important. So I've started measuring margins on all of my procedures now too.
How?
Yeah. So again, I really rely on my PACS. My PACS, again, is able to co-localize everything, and you're able to show one over the other in order to see kind of the before and after and kind of measure to make sure. I target at least 5 millimeters, but ideally a centimeter if I can.
Okay.
Which goes back to the tumor size question you asked, in the beginning, which, greater than 3 centimeters. If you want a 1 centimeter margin, you need a 5 or 6 centimeter burn. And, now you're talking about multiple probes and stuff like that. The procedure just becomes more complicated. And I don't think I'm skilled enough as an interventionalist to make it super complicated.
So, I mean, in your planning phase, though, and you're looking at a tumor that's greater than 3 centimeters, and you want to get those margins, how do you know when you're going to need multiple probes, as part of your planning process?
When in doubt, do more. That's it. If you're on the fence about maybe I should add an additional probe, every single time I haven't, I've regretted it.
Yeah, totally.
And it's just more is better.
And, you compare it to the kidney, I have no problem being a little bit more aggressive. Rarely do I regret it adding another probe.
No, the most important part of the procedure, I guess, short of not having a complication, is making sure you get ablation margins.
Yeah, I'm with you. Okay. So you talked about doing a pre-procedure embolization, so I was doing a taste before. Do you use size as the primary determinant, for whether or not you do that?
No, I really have found ethiodized oil, poppy seed oil, to be really helpful for tumor localization. So if I know it's going to be a hard tumor to localize for whatever reason, that's another reason to do a taste. I use conventional taste for that reason, to stain the tumor. Not only are you going to get the micrometastatic disease around the tumor, but then when you go and do your ablation, you're gonna have a kind of a nice roadmap of where you need to go.
Yeah. Okay. What about biopsies? Do you ever do a biopsy when you're in there?
I do. It's not every single time. If a tumor is a LIRADS 5, we know this is HCC. We've treated 5 HCCs in this guy before. No, I don't do a biopsy. My oncologist, though, really enjoys having biopsies. Even if these patients are not going on to systemic therapy now, there's a lot of evidence coming out of sequencing and figuring out which patients particularly would benefit from some of their therapies. And so I get tissue if at all requested.
I have the same thing.
Sorry, it's another thing that really differentiates us from other people who do therapies. We offer both diagnosis and therapy, which is something unique to us.
Yeah, it's not as much of an issue in the liver as it is for the kidney, but I still always tell patients, if a biopsy's been requested, that I'm going to prioritize the ablation. If I can do both, I will, but if it's one or the other, I'm choosing the ablation.
So I don't do kidney ablation because I work in an academic center. I have partners who can do that. I've always been worried. So I'm sorry, I'm going to flip the table on you for a second, but I'm always worried whenever I do a biopsy before an ablation, I might get a hemorrhage that might I tell
a story to my patients every time because I had one early in my career where I went to do the biopsy first on a kidney, a peripheral lesion, and it bled. And, I had 2 choices. It's like bring them back and do it again or do a bigger burn. And it was a challenge. And I ended up treating it successfully, but it took forever. It was a larger burn than I wanted to do. And so now, for kidneys, same way I do with liver, it's like I get the probe in first. And when the probe is in, then I'll do the biopsy if I have room.
Yeah, that makes total sense. And I like I said, there's been a number of times where, if you read my clinic note, it says it's going to be a biopsy and ablation. And you just get in the procedure and you're like, there's no way both of these are going to happen.
No, I mean, and I know that for a small lesion that I can't fit an ablation probe and a biopsy needle into, I'm getting margins. This thing is going to be gone. And so, to me, the biopsy is less important than the burn.
Yeah, 100%.
So let's talk about some common challenges. And some of the challenges I was going to ask you about are probably much less so, using your navigation software and of course with pre-procedure embolization as well. One thing I come across all the time is that, I'll get in there and I can't see the tumor at all. And I've gotten very good at targeting based on landmarks, using veins, using, occasionally you can get a fiducial marker, something like that. But sometimes it's a little more guesswork than I would like, and I know that is less of an issue for you now, but before you had this navigational software, how did you approach that?
So, even without the navigational software, the concepts of doing a arterial or venous phase, whatever shows up better, contrast enhanced CT in the exact position that the patient's prepped, ready to go, that you're going to do your ablation in, then you can use just your normal packs. We have Visage, but all of them have done it. As long as you're doing it in apnea. And another trick I learned the hard way is the valve for the anesthesia machine has to be open so that the lungs are equilibrating with room air. So it's the same pressure inside the lungs so that the liver and everything is in the exact same place every single time. You do your contrast enhanced CT in the beginning. Don't move the patient after that. Then you can, in between each control scan, you can then use your packs to kind of colocalize and see exactly where you're at. Because I used to do everything that you were describing, but once I discovered how easy that technique was, that's what I do universally now.
I'll have to pick your brain on that. We use Visage as well. And I'm a guy that, for a small lesion, I'll go through 10 pairs of gloves, just like stepping out, taking my gloves off, reviewing everything, measuring again. I need to figure out how to optimize Visage to do that.
So I always joke sometimes with my fellows too that I should have bought stock in whoever makes those gloves.
Oh, absolutely. I am, for any ablation, I go through as many gloves as I want to. My techs will just leave a stack for me, whereas my partners will have like one pair of gloves out. Mine, I have a stack because I don't like to have the techs reviewing the image, scrolling through the images. I like to do it myself, and I just burn through those things. Some other challenges, we can have in terms of difficult locations, and one that I get sent a lot is I get the ones that are in the dome, and I'm curious how you approach those.
Yeah, if you look at, particularly a lot of the evidence looking at SBRT versus ablation, ablation does better, except where you get kind of suboptimal ablation areas. And that's almost always the dome, right? Because you're not going to have precise positioning. You're not going to have, exactly the margins you want and everything else like that. In the beginning, I used to use the Varian needle to drop the lung iatrogenic pneumothorax and, then do the ablation that way. These days, it really just feels like that's so much extra work. For those I consider unablatable, I just use ablative radioembolization for those dome lesions. Because, I really love ablation, but you're not going to love ablation once you start having a lot of pneumothoraces or, chest tubes having to go in, or you're just missing tumors, or, it can be a 1 hour, radioembolization where you're drinking coffee half the time, or it can be like a 4 hour ablation where you're like, oh man, this guy can have to go to the ICU.
Totally. Yeah. I've played with everything with that, angling the gantry, and most of the time you can tell beforehand if it's doable or not. And occasionally I'll get the one where it's like, look, tell the patient, I'm going to get you on the table. I don't know what this is going to do when you're prone or on your side, and we're going to try it and see. And every now and then you get burned, but I think that's an important point, is knowing when not to do it.
Mm-hmm. Yeah, it's a phenomenal technology. It is really good at destroying, particularly microablation, it is really good at destroying everything within its path, which is kind of what you want when you have these small tumors. But it can get you into trouble too, because it does not discriminate between anything.
No, it certainly doesn't. And so, that's another question I have, is talking about everything in its path. And let's talk about like really deep central lesions. What are you trying to avoid going through? We're always going through something, and you kind of feel it sometimes, like, oh, I don't like the way that feels. Like, what do you try to avoid?
Bile duct, without a doubt. That's my biggest fear, is burning a bile duct. We've definitely hit some veins, hit some arteries, and you do get potentially bigger, devascularized zones than you were anticipating. And that's usually okay. Obviously, if the patient's, well compensated and everything else like that. But if you hit a bile duct, we've had some bad outcomes with that. So that's the only thing I'm very careful about in dodging.
How do you avoid that?
Good ultrasound skills. I might do a hybrid. So let's say it's a deep lesion or a dome lesion you can't see on ultrasound. I might start with ultrasound to get me along the trajectory in the right place that's going to avoid the central biliary system or, large portal veins and stuff like that. And then once I know I'm past them and deep enough into the liver, then I'll switch over to my CT and do the rest of it with CT guidance that way, once I know I'm kind of clear of that.
And are we talking primarily large bile ducts and not, the small ones you see on the way?
Yeah. No, I'm talking central bile ducts, yeah.
And then, are there any other areas you worry about burning? I remember early in my career hearing a lot about avoiding the abdominal wall, avoiding the diaphragm, the capsule. How do you approach lesions in those locations?
I was super nervous about capsular lesions, but UCLA did a really good, it was a retrospective evaluation of all of their kind of subcapsular and pericapsular tumors, and the rates of bleeding were not larger and the outcomes were equivalent. And so that kind of really eased my kind of fears about that. We have a really busy palliative ablation practice, and you get really comfortable with hydrodissection with that because these are big tumors like in the abdomen against bowel and everything else like that. So you're always hydrodissecting something. So we've gotten, really comfortable with that. So if it's really close to the abdominal wall, I iatrogenically cause some ascites, kind of push the liver away. Same thing with bowel or gallbladder. You can slip a needle in between the wall of the gallbladder and the liver capsule, kind of push it out of the way a little bit.
What are you using to hydrodissect?
It's 50 cc's of Omnipaque 240 into a liter of saline.
And how much do you typically use? I mean, I know it depends on the location, of course.
Yeah, I'll start with 60 cc's if it's going smooth and do a scan. Make sure it's in the right place. Make sure it's kind of doing what I want it to do. It's not kind of just layering somewhere else. And then if that looks good, then I'll put another 200 in. And then again, as you're doing the procedure, you're going to have ultrasound visualization of what's going on. So you can have someone pushing more in as you're doing the procedure, either a tech or a fellow or something like that.
What size needle do you use for it?
The hydrodissection 22 gauge.
Yeah, me too. The standard setup on my system is 10 minutes for 65 watts. When do you adjust that?
I hope I've convinced you I'm sophisticated so far about how I think about these things. And I remember in my training, I had the guy who taught me, Steve Rose, always did the same thing. He must have used a different system, so it was 100 watts, 10 minutes. It wasn't even a question. It was just as soon as you were in the room, 100 watts, 10 minutes.
Every time.
And then when I first started, I'm like, no, I'm going to be sophisticated. You have apps on your phone that tell you like, oh, your ablation size is going to be this and this and this for whatever minutes. After about a year or two, I just went to bigger is better. So I do the equivalent of whatever, for the most part, whatever the max is.
Okay. All right. How long?
It's incredibly unpredictable.
It is.
If you look at what they tell you, and there's actually a great review article, and I forget the name off the top of my head, but I actually went through all of the laboratory evaluations that they had to do in order to get their 510K clearance. And they show you that sometimes ex vivo for this probe is better than in vivo, and then for this probe it's not, and then sometimes it doesn't correlate well, and sometimes they don't even do it in an animal model. It's just in an agar plate. Just more is better.
Okay, I like it. So you're done with your ablation, and the patient's done well, of course, and they've gone home. When do you image again after?
So we usually do a month with ablation. You can usually get a good result in a month. Make sure everything's okay, everything looks non-viable as you expect, and then after a month we then go to every 3-month imaging, back to routine surveillance.
So a patient who can handle breathing instructions and no renal issues, do you have a preference between CT and MRI?
I really enjoy MRI. I think CT can hide a lot of things, and if I might feel better about myself not having the viability returning that quickly. But I would much rather treat a 5 millimeter recurrence than when it becomes 2 or 3 centimeters.
Totally. Absolutely. Any other tips and tricks to share for completing successful ablations?
Yeah, get really good at ultrasound. Because I taught you all these fancy techniques with co-localization and contrast scans and everything else like that. But if there's a tumor down in segment 5 and I can see it great on ultrasound, a microwave ablation can be a 5-minute procedure. Really, really, really get good at ultrasound because that's going to really help you out.
Any other tips for somebody that is just starting to go to these tumor boards and wants to make a name for himself or herself and start doing these procedures?
Yeah. I think the most important thing you can tell someone who's kind of just getting started out is be comfortable saying, no, I have nothing I can do. Eventually, as you get more experienced, you'll start saying that less and less and less and start taking on crazier and crazier and crazier cases. But at least in the very beginning, be comfortable saying, like, if it's going to be really difficult for any treatment modality, feel comfortable saying there's nothing I can do here. Conversely, for your first ablation case, highly recommend segment 5, segment 6, see it under ultrasound. You're gonna be so nervous just from doing your first case. Don't make it hard by making it hard localization. And choose really easy cases to start off with, because you're gonna have great results. It's a fantastic technology. It works. It's been proven to work for decades. And so just make sure you can utilize the technology where it really shines.
Totally agree. And this is one of my favorite things that I do. I was talking to a med student the other day who was thinking about going into IR, and she was asking me what we do, and I spent a lot of time talking about ablations, and a lot of what we do, we can help things, but not necessarily cure them. And you can take somebody with, a small lesion and you can cure the patient of cancer. And there are not a lot of things that we do that are like that. And one of the reasons it's one of my favorite things.
Nothing is better than that clinic visit.
Totally. Absolutely. So just one more thing I have. We talked about how you have some research going on microwave ablation. Can you tell me a bit about it?
Yeah, it's just an ablation in general. I think the future of IR, at least one of the futures of IR and IO, is going to be utilizing ablation to kind of control the tumor microenvironment and the immune system. And so you can really expand our repertoire and have better outcomes once we start looking at that. So at my institution, we have a couple of trials, phase 1 trials that we've opened up, looking at the combination of different types of ablation modalities with immunotherapy. One in the liver using cryoablation for HCC, and then also in the pancreas using IRE with immunotherapy both locally and systemically. And that's another one of the benefits of our job, is that we can give really high doses of types of immunotherapy that boost the immune system that can't be given systemically. So you can kind of give it like the trifecta of systemic immunotherapy, localized immunotherapy, and then kind of boost everything with a huge bolus of antigen from your ablation. So I'm really optimistic, cautiously. I don't want to get the cart before the horse, but I'm optimistic there's going to be a role for us with improving immunotherapy response with ablation.
That's exciting. I look forward to seeing the results. Can you share some cases with us?
All right. So ablation is just like real estate. Location, location, location. Location matters. So when I think about it, I like it to be peripheral, but not too peripheral. Although with a little asterisk, because I kind of told you earlier that there is data to support peripheral lesions. Love it to be targetable by ultrasound, not near the hepatic dome, and obviously not near other important structures. For the person just starting out in their practice, this is kind of the ideal tumor. A 2-centimeter tumor right in the middle of segment 5. There's no ribs in the way. You're going to see it. You're going to get your 1-centimeter margins. Seeing this in your tumor board, this is going to be a complete response, and you're curing this particular tumor.
Totally.
I'm a big fan of when you're starting off, this is the tumor you want to treat. This is one of the great examples of kind of what we did in the past. So here you can see in segment 8, there is a tumor going to be very difficult to treat. Again, as we were talking about earlier with dome lesions, can't see it under ultrasound. So here you can see a TACE procedure being performed with the angiogram right here and the tumor blush, as you can see right there, and great targeting of the tumor. You're able to put Lipiodol into it. We ended up causing an iatrogenic pneumothorax. You can't see the needle on this, and then took a transportal route with, you can see the little tine tier of the radiofrequency probe. I was kind of dogging on radiofrequency earlier, but this patient's 5 years out, right? Like here you can see the ablation cavity immediately, but this is a durable response 5 years later. That's a cure. Microwave ablation, kind of as I was talking about earlier, this is another one of those like really good cases to start off with. You really see the hyperechoic tumor very easily under ultrasound. So you can have a nice direct visualization of your probe going all the way in. At this point, I'm not showing it here, but I do measure what I think my ablation is going to be based on what the vendor says as part of their specs, just to, I think, more make myself feel better. Because as soon as you start ablating, you start seeing kind of just the gas bubble and can't see anything. We started doing contrast-enhanced ultrasounds on the table. Contrast-enhanced ultrasound is kind of free. You don't have to worry about the contrast like you do for CTs on the table. And you can really, once you get good at it, if you see any, you can really see the margin that you did or didn't get, and so you can re-ablate right there on the table. And again, since you don't have to worry about the kidneys, it's just breathed out in about 4 or 5 minutes. You can go immediately back in and re-ablate. So I really like contrast-enhanced ultrasound for these. This is that same patient. So you can see a CT scan we acquired, again, with our microwave ablation probe this time, right on the hepatectomy bed margin. You can see a nice kind of cavity being developed, and 3 years later, you see a kind of shrinking ball of where the tumor used to be. Combination therapy, I know we were talking about that earlier. It really is a useful technique. This patient was treated 2 weeks later after it. So you can see during our TACE, we have good pacification on our cone beam CT. And when he came back 2 weeks later, not only is the tumor smaller, you can see kind of the shrinkage right there, but now it's really easy to treat. Particularly with CTACE, I do like to give a little bit of a washout because the kind of peripheral, residual epiidal takes some time to wash out. But again, this is one that maybe the tech could scroll through and you'll feel comfortable that you got it. And then this is an IRE case that I did. IRE obviously is a little bit more difficult because you have to, worry about the precise measurement of your probes. But here was a 1 centimeter tumor. The bowel was right there in the way of everything. Couldn't hydrodissect it out because the patient had previous surgeries. It was kind of stuck to that location. So we chose to do IRE, doing 3 probes to get a little triangle. And you can see at our follow-up CT, we had a great response. So it definitely has a role in select patients. It is significantly harder to use, but it can be used in places where you can't use other therapies. And then lastly, cryoablation. This is a good case of mine. It's a small tumor, so I know I'm not going to need a huge ablation, the benefit of microwave. And here's a rib. I can convince you of that. And I know the intercostal nerve is right there. And I know if I use a microwave ablation probe here, I'm going to be getting a call for a month or so with, intercostal pain. And so, we do intercostal cryoneurolysis all the time for different types of malignant pain. So I was able to get the ablation probe. And here we use robotic guidance to get really precise placement. Freeze, knowing that even if I freeze the nerve, I'm probably going to be okay. Maybe she'll have some skin numbing, but I know I'm not going to have a burn or anything like that. And then here you can see this is about a year later, where it's just a little nubbin of where the metastasis used to be. So again, just like all IRs, use your different modalities, kind of be a jack of all trade, but also kind of a master of all of them too. But that really will separate you. Just lastly, there is one randomized trial showing that cryoablation has similar overall survival and tumor-free survival compared to radiofrequency ablation.
Zach, that's all I got. That was fantastic. Thank you for sharing your time and your expertise. Is there anything I missed that you want to talk about?
No, that was a phenomenal discussion, and I learned a lot too, so thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.